So, ladies and gentlemen, it's my pleasure to welcome you to another CECOG Academy event. My name is Christoph Zielinski, and I'm president of the Central European Cooperative Oncology Group, and we've been together for I don't know how many years. In fact, we started in 1999. And by coincidence, this is the year when the first big data were published concerning HER2/neu and the influence upon it by therapeutical means. Now, you all know, of course, that HER2/neu was a major discovery which occurred around the late 80s, early 90s, and signified the worst prognosis in patients with breast cancer. All this was turned around dramatically after an antibody called trastuzumab was developed, which aimed exactly at HER2/neu, thereby changing the fate of patients with HER2/neu overexpressing disease dramatically. This was first the case in metastatic breast cancer, and then turned out to be also the case in early breast cancer. And I remember very well when Martin Picard presented this data in 2005 at the American Society of Clinical Oncology meeting, that the results were really greeted as if she were a superstar and member of the Rolling Stones band. Now, this truly has changed things dramatically. But not only did it change things, it also led to new discoveries. So ever since we knew about trastuzumab, a series of other compounds were developed, which are right now used either concomitantly with trastuzumab or can be used in sequence after trastuzumab failure. Now, this was the case particularly during the last very few years, in fact, months. And the scenario of treating patients with HER2/neu overexpressing breast cancer has changed very significantly during this period. Now, today's seminar and webinar is intended to shed light exactly upon these changes, exactly upon these changes in treatment paradigms, and wants to introduce to you the most modern strategies we have now today for the treatment of early breast cancer, advanced breast cancer, and finally, which has emerged during the last couple of, again, very few years, HER2-low breast cancer, which emerges not really as a new entity, but it does emerge as a new entity where certain treatment options are available. Now, it's my pleasure to welcome a very excellent faculty consisting of Dr. Simona Borštnar from Ljubljana, the Division of Medical Oncology, Professor Rupert Bartsch, who is Chief of the Breast Cancer Program at the Department of Medicine 1 at the General Hospital in Vienna, Austria, and myself, who I will talk about HER2-low breast cancer. Now, I want to thank the sponsors and supporters of this meeting. This was AstraZeneca, which supported us with an educational grant to make this possible. Ms. Ursula Fischer, who has always helped us in the entire infrastructure, the organization, and the entire setup which is needed for such a webinar. And finally, Mr. Dietrich, who is responsible for the technique and the video transmission. So thank you very much for joining us. We're very happy that you are with us, and I would want to now give the floor to Dr. Simona Borštnar, who will talk about HER2 targeting antibody treatment in early stage breast cancer. Simona, please.
Good afternoon. I'm very glad that I have opportunity to give a lecture about anti-HER2 targeting therapy in early stage breast cancer. So there are my disclosures. So we all know that the incidence of HER2 positive early breast cancer among all breast cancers is about 15 to 20%. So 1 of 5 women will be diagnosed with HER2 positive early breast cancer. And we also know that still 1 of 3 women with HER2 positive early breast cancer will still develop metastatic disease and will die because this disease. Out of retrospective trials, we know that the prognosis of HER2 positive disease is very poor without trastuzumab treatment. So the outcome of HER2 of patients with intrinsic HER2 positive disease is without proper treatment as so poor as in basal-like cancers and much worse than in patients with luminal A and luminal B cancers. But this was before the era of trastuzumab. So we all know already 15-year results of pivotal trials which investigated addition of trastuzumab to standard chemotherapy in patients with HER2 positive early breast cancer. And this pivotal study showed that adjuvant trastuzumab in combination with chemotherapy was shown to reduce the relative risk of recurrence by up to 40% and relative risk of death by up to 30%. And the benefit of trastuzumab was across all groups and independent of patients' tumor characteristics. So, but now we are 15 years later, and now is the question how to treat our HER2 positive early breast cancer patients, either with neoadjuvant treatment or first with surgery and then with adjuvant treatment. And one decision is how large is tumor and if axillary lymph nodes are positive or not. So nowadays, majority of patients with tumors larger than 2 centimeters with or without metastasis in lymph nodes are treated with in a neoadjuvant setting. And the patients with small tumors and negative lymph nodes are treated with anti-HER2 therapy in adjuvant setting. But how to know how to treat which individual patients? So when adjuvant therapy could be must be escalated or extended, or when maybe less toxic chemotherapy is good enough for our patients. So first question about escalation and extension. And we all know very good data out from Affinity trial, which was randomized, double-blind, placebo-controlled phase 3 trial, which investigates if pertuzumab, in addition to trastuzumab and chemotherapy, improve disease-free survival, and it was investigated also if improve overall survival. And results of this trial showed us that yes, there is the role of pertuzumab, because combination of pertuzumab and trastuzumab reduce the risk of disease for 19% and improve 4-year overall survival for 2%. And this difference was found in patients with metastasis in lymph nodes. However, in patients with nodal negative disease, this difference was not significant. And regarding to hormone receptors status, there was a larger difference in patients with hormone receptor negative disease. However, the groups was smaller than in intention to treat population, and in neither in patients with hormone receptor positive disease, either in patients with hormonal negative disease, this difference was not statistically significant. But still, on the basis of affinity trial, we know that in patients with high risk HER2 positive disease, we need to treat them with double anti-HER2 therapy instead trastuzumab alone. So next important trial was ExteNET trial, which investigate prolongation of anti-HER2 therapy. In this study, the patients treated with standard chemotherapy and trastuzumab therapy was randomized to receive neratinib or placebo. And study was positive in the similar amount than affinity trial, but we must be aware that patients who were treated in this study received previous trastuzumab only, not trastuzumab and pertuzumab. The analysis in regarding to hormone receptor status showed that neratinib is actually most efficient, is active more in patients with hormone receptor positive disease than in hormone receptor negative disease. So what about de-escalation of adjuvant treatment? So the small, not randomized open trial in patients with tumors smaller than 3 centimeters with adjuvant paclitaxel weekly, 12 cycles weekly, in combination with trastuzumab showed very good efficacy. Actually, 7 years disease-free survival was 93%, and so good results was found in both patients with hormone receptor positive and hormone receptor negative disease. Furthermore, another phase 2, another trial, this was phase 2 trial, also investigated maybe more effective approach with TDM1 compared to paclitaxel and trastuzumab alone. So again, in this study, the patients with low stage of disease with negative lymph nodes or up to 1 positive lymph nodes with micrometastasis were included, and the study showed that there is no efficacy advantage in patients treated with TDM1 compared to trastuzumab and paclitaxel alone. So in patients with stage 1 disease, on the basis of these studies, in majority clinical cases, we use less toxic therapy with paclitaxel alone in combination with 1 anti-HER2 drug, this is trastuzumab. What about neoadjuvant therapy? What is actually the reasons for use of neoadjuvant therapy, not only in HER2 positive disease, but also in other 2 subtypes of breast cancer? So first, very good goal of neoadjuvant treatment is to reduce tumor size, increasing chances that patients can have breast conserving surgery rather than mastectomy, and very important potential for less axillary surgery. With neoadjuvant therapy, we can treat patients at high risk for metastatic disease with systemic therapy before surgery, as soon as possible. We can see how tumor responds to the treatment, and we can change the plan of treatment. And most important, we can assess pathologic response at surgery and plan the treatment after surgery. And we also know that with use of neoadjuvant therapies, no difference in survival comparing to patients who have chemotherapy after surgery. So why is achieving to pathological complete response so important? Again, on the basis of retrospective trials put in a big analysis which was published 7 years ago, it was found that patients with HER2-positive disease with pathologic complete remissions has better disease outcome than patients without pathologic complete remissions. The hazard ratio was 0.39. And this difference was even larger in patients with hormonal receptor negative disease. The same results was, of course, found also in a meta-analysis of 52 publications with almost 30,000 patients included in this analysis. And this meta-analysis showed that PCR pathologic complete remission is associated with better event-free survival and also with improved overall survival. The difference was big, and we know that PCR after neoadjuvant treatment is a very important goal in treatment of our patients. So previous mentioned pooled analysis showed also then when we compare patients treated with chemotherapy alone or combination of chemotherapy and trastuzumab, there is a big difference in a percentage of pathologic complete responses. And actually, the amount of complete pathologic complete responses was doubled in patients who was treated with both chemotherapy and trastuzumab. And most important clinical trial in neoadjuvant setting is NeoSphere trial. The aim of this study was again to find which combination of therapy is connected with best pathologic complete response. And patients were randomized to preoperative treatment with taxanes and trastuzumab, taxane therapy, trastuzumab and pertuzumab, combination of trastuzumab and pertuzumab, and combination of taxane therapy and pertuzumab. And it was found that the best response was achieved in patients treated with double anti-HER2 therapy, trastuzumab and pertuzumab in combination with taxane therapy. We must be aware that all these patients was after surgery treated also with anthracycline chemotherapy. But anyway, on the basis of NeoSphere trial, the combination of trastuzumab, pertuzumab, and anthracycline and taxane-based chemotherapy became standard treatment in patients with stage 2 and 3 HER2-positive early breast cancer. So with such approach, the neoadjuvant systemic therapy in HER2-positive disease is optimized, and over the last 10 years, PCRs in HER2-positive early breast cancer has been improved, and we can achieve nowadays in routine clinical practice actually complete pathologic complete remissions in 3/4 of all our patients. So, and now we have a new question, how to treat patients without pathologic complete remission after neoadjuvant chemotherapy. We know that patients with residual disease have worse outcome, and we must add additional treatment to them to improve disease-free and overall survival. And most important study which investigated these questions: which therapy which therapy is better than trastuzumab alone as neoadjuvant treatment, as adjuvant treatment after previous neoadjuvant treatment. And in this study, patients with residual disease were randomized to either T-DM1 or a standard therapy with trastuzumab up to 1 year after previous neoadjuvant therapy. And primary endpoint in this study was invasive disease-free survival, and secondary endpoints disease recurrence-free survival and overall survival, and of course safety. And the study was more than positive. The results showed that T-DM1 actually reduced the risk of disease for 50% compared to trastuzumab. And this was found. This difference was found for disease, distant recurrence, local regional recurrence, contralateral breast cancer. However, it was not established the advantage in reducing risk of metastasis in brain. So overall survival was not significantly better in patients treated with T-DM1 in comparison to trastuzumab, but there was a difference in a few percent also in overall survival. However, still results are still negative. So on the basis of all this trial in adjuvant setting, neoadjuvant setting, what is nowadays the algorithm of treatment of our patients? When we have patients with stage 1 disease, then it's quite good, and it's maybe optimal option to start treatment with surgery. And after surgery, we must treat patients with adjuvant chemotherapy and in combination with trastuzumab alone. It's not necessary to always add also pertuzumab to this group of patients. In chemotherapy, possible options is to use taxane chemotherapy alone, for example, paclitaxel weekly for 12 cycles. However, in patients with stage 2 and 3 disease, it's better to start treatment with neoadjuvant therapy in combination with anthracycline based chemotherapy followed by taxane therapy, combined this taxane treatment with trastuzumab and pertuzumab. So possible chemotherapeutic choices are dose-dense chemotherapy with AC scheme followed by paclitaxel, or other schemes with anthracycline and taxanes. It is possible to treat patients also without anthracyclines with TCA, with combination of docetaxel, carboplatin, trastuzumab, and pertuzumab. After neoadjuvant treatment, of course, surgery followed, and in patients with pathologic complete remission, then we must continue treatment with either trastuzumab alone or combination of trastuzumab and pertuzumab in patients with initial metastasis in axillary lymph nodes. And in patients with positive hormonal receptors, of course, we must add hormonal therapy. So in patients with residual disease after neoadjuvant treatment, we must switch treatment with trastuzumab and pertuzumab to T-DM1 for additional 14 cycles up to 1 year of whole anti-HER2 treatment. And in patients with positive hormone receptors, we must add also endocrine therapy. So maybe in patients with positive hormonal receptors and high risk disease, positive lymph nodes, we can add also treatment with neratinib. Neratinib is not available for our patients in our country, but when in countries where neratinib is reimbursed, maybe that is still option in a few patients with high risk disease. So what about adverse events? We know that anti-HER2 therapy is very good tolerable treatment. During trastuzumab and pertuzumab, we must monitor cardiac function with echocardiographs. T-DM1 is slightly more toxic, but still very tolerable. The most frequent adverse events are thrombocytopenia, increased liver transaminases, and peripheral neuropathy. However, other toxicities are similar than in trastuzumab-pertuzumab treatment. Neratinib is a less tolerable therapy, and as in treatment with another small molecules, diarrhea and rash could be problems, and other toxicity are comparable to another anti-HER2 treatments. So in conclusion, HER2 targeted therapy has improved outcomes in HER2 positive early breast cancer and become standard of treatment in the last 15 years. Neoadjuvant chemotherapy with dual HER2 targeting agents, pertuzumab and trastuzumab, is considered as optimal approach for patients with stage 2 and 3 HER2 positive breast cancer, and we know that patients achieving pathological complete remissions tend to have better long-term clinical outcome than those who do not, and that's why trastuzumab emtansine is there to improve disease outcome in patients with residual disease following a neoadjuvant HER2-directed therapy. Thank you.
Thank you very, very much. This was an excellent overview, Dr. Borštnar. Of course, as usual, we have a couple of questions. Mm-hmm. And the first is maybe again to highlight a little bit the optimal duration of anti-HER2 directed treatment, because there were so many different reports. Would you want to comment on this?
Yes, of course. Yeah, there was trials which investigated if 6 months or 8 months of therapy, anti-HER therapy, are equal to 1 year therapy. And HER trial also investigated 2-year therapy in comparison to 1 year therapy. On the basis of this, all these trials, 1 year treatment is still optimal. 2 years is not better than 1 year. However, the trials which investigated a shorter duration of anti-HER2 therapy was not that showed actually that maybe 6 or 9 months of anti-HER2 therapy also will be enough when maybe in countries, in patients, when 1 year treatment is not available, and but still 1 year stay the standard duration of therapy. And when we treat patients neoadjuvant and then adjuvant, the whole duration of treatment should be 1 year. When patients become 4-6 cycle of anti-HER2 therapy preoperative, then it's not necessary to treat them with another 1 year therapy, but together preoperative adjuvant with 1 year. So it was clear enough.
Okay, thank you very much. That is an important clarification. Sure. And another question that we have here is the optimal choice of an anti-endocrine treatment in the case of HER2 positivity and endocrine dependence. Could you comment on this?
Yes. My decision in clinical practice is the same as in patients with hormone receptor positive HER2 negative disease. In postmenopausal patients, actually, I treat all patients with aromatase inhibitor. In premenopausal patients, mostly with tamoxifen alone, sometimes with medicamentously ovarian ablation and aromatase inhibitor if the prognostic factors are very poor. However, there is no study which showed, especially for HER2 positive disease, if aromatase inhibitor is better than tamoxifen. There was some studies 10 years ago, but was not very practice changing. So the decision is actually the same than in patients with HER2 negative disease. And duration, again, at least 5 years in some patients with poor prognostic factors behind those 5 years to up to 10 years.
Okay, super. Thank you very much. So these were the questions that emerged. Thank you very much for this excellent overview and your phenomenal expertise. Very much appreciated, and thank you very much for joining us. And we're coming to the next talk, which will be given by my long years friend Rupert Bartsch. So we grew up together, sort of. I mean, there were a couple of years between us, but nevertheless, I grew old and he ripened. Let's put it that way. And Rupert will talk about HER2 targeting antibody treatment in advanced and the metastatic stage. Please, Rupert.
Christoph, thanks very much for the kind introduction. Thanks for the invitation. Really great being here with you. So after Simona's excellent talk, it is clear that we do have a problem in the metastatic setting because all these wonderful drugs, as Christoph has said, starting from trastuzumab, are now being used in the adjuvant setting. So a patient who recurs after adjuvant therapy will definitely need novel treatment approaches. I will now shortly discuss those potential novel treatment approaches with you. These are my disclosures. That's where we started from. Christoph already said it. Patients with HER2 positive breast cancer before the onset of trastuzumab treatment had a very poor prognosis, and the overall survival from the diagnosis of metastatic disease was less than 2 years. So in those patients and in those days, we were in the range of triple negative breast cancer today. That has changed dramatically. This is where we stand today with docetaxel, trastuzumab, and pertuzumab in the first-line setting. We're achieving overall survival in the range of 5 years. And as you know, we are most probably much beyond that already. In the second-line setting, the traditional standard now for nearly 10 years was TDM1, which was actually the first antibody-drug conjugate we had available in breast cancer. So 3 molecules of TDM1, an antimicrotubule agents, are bound to trastuzumab. It's a kind of targeted chemotherapy, therefore well tolerated and highly active, at least in homogeneous HER2 overexpressing cancers. And we know from the phase 3 trials here of Emilia and down Teresa that in fact it's better tolerated and more active than the classic second and beyond second line treatment standards of capecitabine, lapatinib, and in Teresa trastuzumab in multiple lines with changing chemotherapy combination partners. Now, what options did we have after that? Well, of course, resorting back to this concept of treatment in multiple lines, we continue trastuzumab-based therapy for as long as meaningfully possible because we know that this will prolong overall survival, and we're exchanging upon progression the combination partner. And the other option, of course, that is what you could call a vertical dual blockade with trastuzumab plus the HER2-directed TKI lapatinib, which binds to the intracellular domain of HER2 and blocks HER2 signaling. And in addition, what lapatinib does, it obviously stabilizes HER2 in the cell surface, therefore increases the number of HER2 where trastuzumab can bind, and therefore to a degree reverse resistance against trastuzumab. You know from the Blackwell trial that this approach prolongs overall survival over lapatinib alone, which of course never was a treatment standard, and that was a typical chemotherapy-free late-line option. So that brings us to the classic treatment standard, the classic algorithm, the old order which we have been grown accustomed to over many years now. First line, trastuzumab, pertuzumab, and docetaxel as the standard treatment for patients fit enough to undergo chemotherapy. TDM1 were available as the second line standard, and after that it's becoming, well, less based on evidence, more the art of oncology, with trastuzumab in combination with different combination partners such as vinurelbine, often preferred, or capecitabine, and of course trastuzumab and lapatinib. And in hormone receptor positive disease, you always have the option of adding endocrine therapy to HER2-directed therapy after induction chemotherapy. And of course, in patients not fit enough to undergo standard treatment, you can also add an AI to trastuzumab, pertuzumab, or trastuzumab and lapatinib. But there are several challenges now to this concept, and not the least of those is the fact that patients now receive all those phenomenal treatment options, trastuzumab, pertuzumab, and often TDM1 in the adjuvant, neoadjuvant, and post-neoadjuvant settings. So on the one hand side, we need options to improve tolerability and activity of adjuvant and neoadjuvant treatment. And then on the other hand side, in consequence, we need novel treatment options in the metastatic setting. We have the problem, and that we have known before, and I'll show it to you in a moment, that TDM1 is not as active in patients who had received prior first-line treatment with trastuzumab and pertuzumab as in the Emilia trial, where patients only had received prior trastuzumab therapy. And then, of course, we have that huge issue of the high rate of patients with HER2-positive metastatic disease who will develop brain metastasis, and of course the holy grail would be the prevention of CNN recurrences, which currently is not possible. Just to show you the problem indeed with TDM1 at the moment, you know that in the Emilia second line trial, the progression-free survival with TDM1 was in the range of 9 months, and it appears in the majority of real-world studies and retrospective analysis that in fact that is much lower, rather in the range of 3 to 6 months. So obviously, it's already a problem in the second line setting, so in patients who progress on first line docetaxel. So what options would we have here in principle? And I will quickly take you through novel developments over the last 10 years. The first is margetuximab. Margetuximab was analyzed in the phase 3 SOPHIA trial. And here margetuximab plus chemotherapy was compared to trastuzumab plus chemotherapy. What is margetuximab? Margetuximab is in fact a modified trastuzumab. It binds to the same extracellular domain on HER2 as does trastuzumab, but it has a genetically engineered Fc gamma domain with the idea of increasing the B cell immune response against the cancer cells. That seems to work to a degree. In fact, in a heavily pretreated population, there was a slight improvement of progression-free survival in patients receiving margetuximab over trastuzumab. As you can see here, 5.8 versus 5.9 months. It's interesting, definitely, but given the data we have now with tucatinib, third generation TKI, or trastuzumab deruxtecan, the third generation ADC, it is clear that this is not a major improvement. And at the moment, we don't have any European approval for margetuximab. Then we have the option of going for novel combination strategies. And one of those in luminal B HER2 positive breast cancer, so hormone receptor positive and HER2 positive, would be the combination of trastuzumab plus abemaciclib as done in the MONARCH-HER study. It was a phase 2 study performed in pre-treated patients comparing the triple combination of the CDK4/6 inhibitor abemaciclib plus fulvestrant plus trastuzumab versus abema plus trastuzumab versus the classic treatment approach of chemotherapy plus trastuzumab. And again, with the triple combination, there was a significant improvement in progression-free survival seen, 8 months versus close to 6 months in the double combination group. And also the confirmed overall response rate was highest with the triple combination. It's an interesting approach, definitely relatively well tolerated, but given that abemaciclib was used here, you will see a relatively high diarrhea rate in these patients. Another approach which is not approved by EMA is neratinib for the use of metastatic disease. And you have heard from Simona before in her excellent talk that neratinib is approved by EMA in the adjuvant, post-neoadjuvant setting in hormone receptor positive, HER2 positive patients at very high recurrence risk. It's not a drug that is so easy to handle because it has a high diarrhea rate, so it requires either optimal co-medication with antidiarrheal agents or a slowly increasing dose over time in order to prevent the onset of high diarrhea rates. Here in the metastatic setting, neratinib was compared to lapatinib, both in combination with capecitabine in pre-treated patients in the phase 3 NALA trial. And as you know, there was a significant, although modest, improvement in progression-free survival shown with a hazard ratio of 0.76, and the time for intervention of CNS metastasis was also improved as well. Does that mean that neratinib has prophylactic properties? You can't be really sure because those patients didn't have any MRI scans at baseline. But you cannot fully rule it out, of course. I would suggest that the superior systemic treatment prevents or prolongs the onset of metastatic disease to the brain or extends the time till pre-existing brain disease becomes symptomatic. But in fact, you cannot rule out that here prophylactic properties are in fact seen. Now, all those improvements are what you could call somewhat modest. And now I will show you the two novel options we have available at the moment. And these improvements have been, in fact, phenomenal. The first is trastuzumab deruxtecan, the second ADC in breast cancer becoming available. Here, 7.6 molecules of deruxtecan and isomerase 1 inhibitor with higher potency than irinotecan is bound to trastuzumab. And the approval is based on the DESTINY-Breast01 trial, in fact, a single-arm phase 2 study. A bit more than 250 patients included. All of them had received prior TDM1, 2/3 also pertuzumab, and more than half after other HER2-directed therapies. Of course, all patients had received prior trastuzumab as well. So in the group of patients receiving 5.4 milligrams per kg body weight, so the standard dose of trastuzumab deruxtecan, there was this phenomenally high response rate. Nearly 2/3 of patients had a response, and the clinical benefit rate was 76.1%. In fact, as you can see down here, the waterfall plot, nearly all the patients benefited from treatment and had some degree of smaller, so reduction of disease burden. And when you look at the progression-free survival data, you see at the ESMO 2021 update, the median progression for the median follow-up of 29.2 months, the median overall survival of 2.5 years, which is very long in a heavily pretreated population, and the median progression-free survival at the San Antonio 2020 update was at 19.4 months. And please bear in mind, again, these are heavily pretreated patients. Here you would expect a progression-free survival somewhere in the range of rather 6 months. So you could argue now that these are unrandomized data. You could argue now that this is a phase 2 bias, and that these patients who made it to these late lines, just remember, these patients had received a median of 6 prior treatment lines, might be serial responders. So of course, to have the final proof of the activity of the drug, we need to wait for the phase 3 trials, and I will go to this in a moment. In DESTINY-Breast01, you can see that all the patients derived benefit from treatment, also patients with stable brain metastasis at baseline, but that was a very small group, and also those patients who had received prior trastuzumab, so there was no difference. So that is the proof of principle. ADC is active after prior ADC, TDXD is active after TDM1. There does not seem to be any reduction in activity due to prior pertuzumab treatment, as is the case with TDM1. And the reason for that is quite probably the highly active chemotherapy, deruxtecan, the cleavable linker that is stable in plasma, the high drug-to-antibody ratio, and in addition, the fact that deruxtecan has the opportunity to go out of the cell again, so it's membrane permeable, and it therefore can kill surrounding cells as well. We call this a bystander effect. Highly active treatment. What about toxicity? Well, nausea is an issue here, fatigue as well, and patients can develop grade 2 alopecia, which means a complete hair loss, although this is rare. When we started treatment with TDXD in summer 2020 within the context of the Tuxedo-1 trial, we first thought this is a drug similar to TDM1, so we only administer 5-HT3 antagonists as co-medications, antiemetic prophylaxis. And in fact, as we know now, that does not suffice, and today we combine it with 5-HT3 antagonists and K1 antagonists and corticosteroids, and now it works very nicely. Fatigue still can develop over time and might require dose reductions, and of course, there's also a risk for diarrhea. Not the most common, but definitely the most discussed side effect is pneumonitis, interstitial lung disease, and the rate of pneumonitis in DESTINY-Breast01 was in the range of 15%, which with 5 patients dying from the disease. So that is obviously something you need to be aware of. It's very reassuring to see that the highest risk is in the beginning. So this is not an effect of the cumulative dose of TDXD. There are nearly no late cases of ILD, but you need to explain it to the patient, and you need to react once the patient reports dyspnea, goes directly to a thoracic chest CT, and treat with corticosteroids if ILD is found, in order to prevent it from getting worse. That is one patient from the Tuxedo trial. It's an ILD grade 2, so slight dyspnea was found. Here on the left side, you can see the interstitial lung disease in both lungs, and here on the right, you see after 2 months of corticosteroid treatment, and here's the same, bit lower down, here clearly to be seen the ILD, and the same here once again. So patient had it resolved completely, but of course she had to discontinue TDXD permanently. That is the case from grade 2 onwards, which is sad because she responded very nicely intracranially and also extracranially. Now let's go to the phase 3 trial, DESTINY-Breast03, and that was the phase 3 head-to-head comparison of T-DM1, the former second-line standard, with T-DXd. Again, all patients had received prior trastuzumab. Prior T-DM1, of course, was not required here, and prior pertuzumab was allowed. Those patients were treated mainly in the second-line setting. A couple of patients also more heavily pre-treated, so a population somewhere in between the Emilia population and the Teresa population. And again, 2/3 had received prior treatment with pertuzumab. And these were the progression-free survival results presented by Xavi Cortez at the ESMO meeting. And I think you will all remember these numbers: a hazard ratio of 0.28. That is something which is unprecedented. We are in the range of 6.8 months with progression-free survival with T-DM1. That is exactly where you would assume it to be in a population of patients who had received prior pertuzumab in the majority of cases. And on the other hand side, a PFS of more than 2 years with T-DXd, as you can see here on the right, in the investigator-assessed PFS numbers. And on the right, there's already a trend seen towards improved overall survival. So obviously, those phase 2 numbers we have seen in DESTINY-Breast01 are for real, and this is definitely a major improvement. What about the subgroup analysis? Here's Sarah Hurwitz's presentation from the San Antonio Breast Cancer Symposium. All the patients derived benefit. The hazard ratio is absolutely the same, independent of prior pertuzumab treatment, number of prior treatment lines, and presence of stable brain metastasis at baseline. Although, and that must be remembered, in patients with stable brain metastasis at baseline, the absolute numbers regarding progression-free survival are shorter, and still the hazard ratio is the same. So the degree in which the patients do derive benefit is the same. Regarding toxicity, as you would expect, more active, but also more toxic. Again, more nausea, vomiting, and diarrhea, as well as fatigue. And 10% of the patients did develop grade 2, so complete alopecia. So please inform your patient that this can happen. What about ILD? Again, it occurs, but with growing awareness, high-grade ILD seems to be something that is becoming rare. Luckily, no cases of grade 4, grade 5 ILD here, and the overall rate drops to 10%. So early intervention, that is something which is necessary and which obviously works in preventing patients from dying from ILD. Now, having discussed very much about the third generation ADC, what about tucatinib? And as you know, tucatinib is there's one C too much here, sorry for that, was evaluated in the HER2CLIMB trial. HER2CLIMB was a large randomized phase 2 trial, recruiting over 600 patients and randomizing patients to tucatinib trastuzumab plus capecitabine or placebo trastuzumab and capecitabine. So basically, it's a chemotherapy consisting TML plus vertical blockade study versus classic TML trastuzumab plus capecitabine, the old standard based upon the GBG26 trial in which also the CECOG participated. All over 600 patients recruited. Tucatinib, as you know, is a third generation HER2-directed TKI. It has a much higher HER2 inhibitory activity. It's more specific for HER2 than EGFR and therefore has a lower diarrhea rate as compared to the first and second generation drugs such as lapatinib and neratinib or pyrotinib. You know the numbers, of course. This clinically relevant, statistically significant improvement of progression-free survival and overall survival in a heavily pretreated population. All of those patients had received prior treatment with trastuzumab, pertuzumab, and also T-DM1. So classic third-line population here. What's so important about that trial, however, is that half of the patients had brain metastasis at baseline, and of those, nearly 2/3 had active brain mets, so newly diagnosed, no prior treatment, or brain metastasis progressing after prior therapy. And here the benefit of tucatinib is, if anything, even higher, with a doubling of overall survival. So that leads us to the novel treatment standard here. First line, of course, it's still docetaxel, trastuzumab, pertuzumab for the majority of our patients. And in the second line treatment, and here ESMO does something very interesting, it already separates patients by the brain metastasis situation. If you have a patient with active brain mets and local intervention is indicated, well, you go to local therapy first. If no local intervention is indicated, then we have a novel standard here, tucatinib, capecitabine, trastuzumab. And if stable brain metastases are present or no brain metastases are present, then the novel treatment standard in the second-line setting, of course, is trastuzumab deruxtecan, were already available, or TDM1. And third line and beyond, of course, the situation is much the same. Active brain metastasis, again, tucatinib, capecitabine, trastuzumab preferred as the systemic treatment option if possible. And no unknown or stable brain metastasis after trastuzumab deruxtecan, it would also be tucatinib, capecitabine, trastuzumab, and then you have still all the other treatment options available, although the evidence is quite low that you would have chosen before. Now, why are we discussing this brain metastasis story so much and discussing systemic treatment so much? Well, because we are increasingly seeing activity of systemic therapy. It all started, of course, with lapatinib, a small molecule, and we hoped that lapatinib would be able to penetrate through an intact blood-brain barrier and therefore provide significant activity against brain metastasis. Now, we know today that this is not true in the complete meaning. Radioactively tagged lapatinib that you can see up here will bind to the brain metastasis. But radioactively tagged lapatinib will not penetrate into the healthy brain tissue. That's a problem here. So obviously, also small molecules do not have the property to penetrate through an intact blood-brain barrier. And on the other hand side, what you can see here, this is radioactively tagged trastuzumab, so a large molecule, an antibody. It also penetrates through the impaired blood-brain barrier, or we call it the blood-tumor barrier, in the area of the brain metastasis. So you can see here an enrichment of trastuzumab in the metastasis. Now, we know very little about the activity of trastuzumab alone in brain metastasis, but meanwhile, we have data from several case series and just recently from the phase 4 Camilla trial suggesting that TDM1, in fact, is active in brain metastasis. That was a patient treated by our own group, where you can see that she responded very nicely with a decrease in the size of the brain metastasis and also a reduction of the edema. And in the phase 4 Camilla trial, 400 patients with brain metastasis baseline were included. Of those, more than 100 had measurable disease. And if you just look at those patients who had no prior radiotherapy, so patients with metastasis but no prior radiotherapy, there the response rate was 50%. What about TDXD? Well, we know very little about it again. We have data, and Guy Jerusalem presented those at the ASCO 2021 meeting. There are responses to trastuzumab deruxtecan also in the DESTINY-Breast01 trial. But please bear in mind, these were patients with stable brain mets at baseline, and these were patients who had received, the majority of cases, prior radiotherapy. That is the only patient who had not received prior radiotherapy in the last month. And obviously, she responded quite nicely to TDXD. The question is still open. There are currently 3 trials ongoing evaluating specifically the activity of trastuzumab deruxtecan in patients with active brain metastasis. There is the active brain mets cohort of the DESTINY-Breast12 trial. There's the DEBRA study ongoing in Portugal and Spain. And perhaps you have heard the first results presented at the December San Antonio meeting, where the cohort responses in the cohort A and C were reported, and in this trial there was a response rate in excess of 50% seen in patients who progressed after prior local therapy. And at our center, the Tuxedo-1 trial is ongoing, and we did present the first results, the preliminary results, in September at the ESMO meeting, and this is just one patient which was included into the Tuxedo trial, and as you can see here, there was a major response here with cerebellary brain metastasis, a complete remission up here, and this patient does very well up until today. And response rate is really nice, and we will be able, I hope so at least, to present the final data at the ESMO Breast meeting in Berlin. Now, one last thing, there are patients who will tolerate systemic treatment very nicely, who will be in remission with their liver metastasis and so on, and then suddenly this patient will develop isolated brain progression. And a question that always comes up is, do we have to change systemic treatment as well in those patients? Well, if there are multiple brain metastases and whole brain radiotherapy is your only option, well, you could consider. But if you have a patient with 3, 4, 5, perhaps 6 or a bit more new brain metastases, today's standard would usually be to go for local therapy of brain metastases, for example, with stereotactic radiosurgery, and continue your successful systemic treatment. Because, and these are data again from the HER2 CLIMB trial, the time to the next progression event is nearly 8 months. So the patient will definitely benefit from continuing the extracranially active systemic treatment while you have treated the brain metastasis locally, so there is no need to switch systemic treatment as well. So where do we stand with systemic therapy in HER2-positive brain metastasis at the moment? Well, it's definitely not replacing local therapy in all cases, but I would believe in patients with multiple brain metastasis and oligo or asymptomatic disease not requiring immediate local therapy, there is the place now to consider systemic treatment. With what is the standard? Well, of course, the standard is tucatinib, trastuzumab, and capecitabine for these patients. There we have the best data, but I just wanted to show you with my last couple of slides that ADCs can be a reasonable second-line option or a reasonable alternative. And of course, once again, do consider to continue active systemic therapy after local treatment in case of stable extracranial disease. With that, I would like to thank you very much for your attention, and I'm happy to take any questions.
Thank you very much, Rupert, for the excellent overview. Thanks a lot. Now, as you mentioned before, of course, the formation of brain metastases generates a major problem, of course. So one of the things which are being discussed always is the question of the blood-brain barrier in brain mets. So would you say that this is something which concerns us in this very context, or is there penetration through the blood-brain barrier given anyhow, or how would you see that?
It's a very important question, and a question that is in fact very hard to answer. So first of all, the blood-brain barrier obviously prevents any successful prophylactic strategy at the moment. This is where we really see a problem. We have seen in the ExteNet trial with neratinib a lower rate, so with extended adjuvant therapy with neratinib, a lower rate of brain metastasis in patients in the neratinib group. But please bear in mind that this trial was not powered to detect such a difference. We have data out there showing that after neoadjuvant treatment, the quality of your response predicts the risk for extracranial recurrence. This is something we know very well. Of course, patients with PathPR have a much lower rate of systemic recurrences, but that does not mean that we can lower the rate of brain recurrences, as brain is the first site of recurrence with neoadjuvant treatment. So patients with PathPR have the same risk of developing brain metastasis as patients without PathPR. Regarding systemic treatment, in case of prophylaxis, we seem to have a problem. Perhaps we will have new data with adjuvant approaches, post-neoadjuvant approaches with tucatinib, but this is far from any standard at the moment, and we do need these data. Regarding the treatment approach, we know that we definitely have considerable activity of systemic treatment in brain metastasis. This goes back to conventional chemotherapy and the 1980s, and the Rosner trial, which was published in Cancer in 1986. We have seen that now with lapatinib, we have seen it with neratinib and T-DM1, and now we see it much more impressively, though, with the novel agents, especially tucatinib, and also, of course, with trastuzumab deruxtecan, where there is accumulating data. But there is one issue. While we definitely can shrink the brain metastasis, reducing its size, there is a second population of tumor cells in the brain which grows along the small brain vessels, and this seems to be protected by the blood-brain barrier. So I doubt that we will ever be able to reach those cancer cells with the systemic treatments now available. So the problem remains. It appears that we are able to contain the worsening of the disease in the brain. We seem to be able to prolong progression-free survival to an extent, but I doubt that we will ever be able to achieve complete remissions, prolonged complete remissions in the brain, as we do now with our systemic treatment options and extragranular metastasis.
Okay, thank you very much. That was very important, I think, to clarify. Good, Rupert, I think there's no more questions left. Thank you very much once again for your excellent lecture and for participating in this event. And we will move on now to another topic, which is a new one, in fact. And this new topic is HER2 low breast cancer. And I will have the pleasure to explain to you what this means and how these things are evolving and how everything is connected with this new idea of HER2 low breast cancer. The next slide shows you my conflicts of interest, so that is my disclosures. And the next slide then is again something which you of course all know, and that is the HER family of receptors, where HER2 is one of the major drivers, and a hetero dimerization with HER3 occurs, thereby leading to an important mechanism which keeps the HER2 positive cell growing and disseminating. The next slide shows you that of course there are a lot of different pathways which are activated by HER2 in breast cancer, particularly PI3K and the AKT pathways, which then lead to both proliferation and survival, and cell growth, protein synthesis, and angiogenesis. And all this is triggered by this receptor tyrosine kinase, which is being activated and leads to the activation of these pathways. Now the question would be, is the activation of these pathways and the biological consequence of those something which is also valid in HER2 low breast cancer, or is it restricted to HER2 positives and overexpressing breast cancers? And I want to look together with you at the evidence that we have right now in this very context. Now, pardon me if I include some very biological thoughts in it and experimental thoughts, which might lead to then the clinical consequences, which I want to discuss with you and let them pass by. The next slide shows you then escape mechanism from trastuzumab, where you all know, of course, that high EGFR expression or overexpression of insulin-like growth factor with the amplification of PI3K pathway play an important role, but also, and that is very important in this context, somatic mutation of the HER2 gene. So we know that particular somatic mutation of the HER2 gene are very important in other contexts, like for instance lung cancer, where we do find a somatic mutation of the HER2 gene also being a target for therapeutic interventions. The next slide shows you then that we are having an algorithm, of course, for the evaluation of HER2 new protein expression by immunohistochemistry of the invasive component of breast cancer. And that is something which has been published in the Journal of Clinical Oncology as a recommendation of this algorithm. And of course, we do have immunohistochemistry 3+, 2+, and 1+, or 0, in fact, HER2 overexpressions. Now, I do not want to concentrate on the immunohistochemistry 3+ or the 2+, which then might become positive by appropriate molecular analyses, but I want to concentrate on the immunohistochemistry 2+ and 1+, which have no molecular background and are just found to be positive upon immunohistochemistry. So the next slide shows you then the definition of HER2 low breast cancers, which has been generated by Paolo Tarantino, in fact, during the last couple of very few years. And here I'm citing for a publication by his and his co-workers from the year 2020 in the Journal of Clinical Oncology, where you might summarize these HER2 low breast cancers as those which are immunohistochemistry 1+ or 2+ with negative or without gene amplification. Those which in the clinic are classified as either triple negative breast cancers or luminal-like, and those which have a HER2 pathway disrupting drug of no clinical benefit. So you see that we are not there yet that we could call this a new entity of breast cancers, but approaching something where we might have new treatment solutions for, and at least consider this subgroup of HER2 low breast cancers as worthwhile considering for treatment options. The next slide shows you then the algorithm for defining HER2 low breast cancers, and you see that here in a graphic setting we have the HER2 positives which are definitely set apart, but we also have the HER2 lows, again the 2+ or 1+, which constitute quite a rather big part of the cake, and therefore might deserve our attention and therefore our therapeutic agility. The next slide shows you then the occurrence of HER2 low expression by immunohistochemistry without gene amplification in breast cancer. And it shows that there is a crosstalk between estrogen receptor and HER2 pathways with modifications by anti-endocrine treatment. So we have this, we have discussed this during the first talk. We have the upregulation, interestingly, of HER2 by chemotherapy and radiotherapy by NF-κB mechanisms, and therefore you might be aware that patients receiving chemotherapy and radiotherapy might be candidates for targeting even low expression of HER2. And of course, epigenetics play an important role where you have an induction of a low expression, which hitherto has not received too much attention, but we feel that it should either already right now or in the immediate future. The next slide shows you then the clinical and molecular characteristics which underline, which I said before, the clinical and molecular characteristics of HER2 low positive breast cancers. And here we have a pooled analysis from 4 prospective neoadjuvant trials, which have been summarized by Carsten Denkert in the Lancet very, very recently. Now, there were in all these 4 trials, and these are from the German breast group, 2,310 patients with HER2 non-amplified breast cancers, and 37.5% of those were HER2 low positive, meaning immunohistochemistry 1+ or 2+ without gene amplification, whereas 52.5% were HER2 0, so having no HER2 expression at all. Now, 64% of these 2,300 roughly patients had tumors of HER2 low positivity and were at the same time hormone receptor positive, whereas 36% were hormone receptor positive and HER2 0, meaning that there is a concomitant, there might be a concomitant occurrence of HER2 low positivity and endocrine dependence. Now, HER2 low positive tumors had a significantly lower pathological complete remission than HER2 0 tumors, 29 versus 39%, which was significant, of course. meaning that probably these patients did not receive adequate treatment, or suggesting that they might not have received adequate treatment by targeting exactly this characteristics of the tumors being of HER2 low quality. Now, patients with HER2 low positive tumors had a significantly longer disease-free survival and 3-year overall survival than those with HER2 zero tumors, which is quite interesting because, again, these patients might, the sooner or the later, get a certain kind of targeted treatment, particularly concerning hormone receptor targeting, which occurs more frequently in HER2 low positive tumors than those who are HER2 zero. The next slide shows you then the question and answers the questions whether there is a stability between HER2 low and HER2 zero tumors. And there is an analysis which was published in Breast Cancer, again very recently, on the analysis of 547 patients. And then these tumors were compared at the time of tumor occurrence, at the time of tumor relapse. Now, the rate of HER2 discordance was very high. It was 38%, with HER2 zero switching to HER2 low 15%, and both HER2 low switching to HER2 zero being 14%, meaning that HER2 low expression is highly unstable during disease evolution, and relapse biopsy in case of a primary HER2 zero tumor may open new therapeutic possibilities if there were some. And I want to show you that there truly are some which we might take into consideration. Now, mind you, this is a very new field, of course, a very new field and a very exciting field, because this has never been really considered to be of any relevance, and we all were concentrating on HER2 overexpressing tumors, which had to be 3+, otherwise we would consider them as not sort of worthy of treating by HER2-directed treatment. The next slide shows you the outcome. Now, HER2 low breast cancers were suggested lately that a subset of breast cancers with low levels of HER2 overexpression and no amplification might truly derive benefit from HER2 targeting. And that is then shown in the next slide, that we do have certain options. There are novel agents and mechanisms which enable the targeting of HER2 low expressing breast cancers, and these are either antibody drug conjugates, like for instance trastuzumab deruxtecan or TDM1. We do have monoclonal antibodies, and finally we do have bispecific antibodies which are currently in development. So we do have a lot of different agents which might very well be qualified for the treatment of HER2 low expressing breast cancers. The next slide shows you then the mechanism of action of these novel HER2-directed therapies with bispecific antibodies which bind simultaneously to different receptors of tyrosine receptor kinases, or which are capable of binding to different extracellular domains, or several agents which are designed to bind to both natural killer cells and T cells, which then bind to the HER2 receptor and then prompt innate or adaptive cell targeting. And finally, which is most interesting currently, is the antibody drug conjugates, because they are the farthest developed right now. Antibody drug conjugates, which are characterized by releasing a cytotoxic payload, which is internalized by the cell membrane in conjunction with the antibody after HER2 targeting. So that is something which is right now the most developed. So the next slide shows you the treatment approaches. Or we're having, in fact, HER2 directed antibody drug conjugates, which are either classical in the mode of action or have a bystander killing effect. So we do have here the possibility to target HER2 even low breast cancers by an antibody directed against HER2 and delivering the cytotoxic payload at the same time into the respective cell. The next slide shows you then the options that we truly have, and these are twofold. It's either TDM1 or currently trastuzumab deruxtecan, and we do have now, when you look at the cell, we do have the possibility to either give TDM1 or trastuzumab deruxtecan. The green cells showing those which die by the addition of the respective antibody and drug conjugate, and the red ones which are non-HER2 expressing cells. So of course what you're doing right here is that you do a certain kind of selection directed at the HER2 positive cell population. The next slide shows you the outcomes. The outcomes are, which we have right now, are quite according to the antibody drug conjugate. So we have TDM1, we have SID, and we have trastuzumab deruxtecan. Now, I want just to draw your attention to the first blue rectangle, which shows that the linker is either in TDM1 non-cleavable, whereas in the other two it is definitely cleavable, and the last and below quadrangle in blue shows that the targeting HER2 low or heterogeneous tumors is bad in TDM1, but very good in SID or in trastuzumab deruxtecan, meaning, in other words, that you do have the ability to target even low HER2 expressing breast cancers with a antibody drug conjugate, would become effective in the respective tumor cell by the delivery of the compound coupled to trastuzumab. So in this case, this would be trastuzumab deruxtecan, where SID is not that far developed as yet. Now, in trastuzumab deruxtecan, it is a topoisomerase 1 inhibitor, and therefore differs a little bit from TDM1, which is an antimicrotubular agent, mitotic poison, and therefore might truly differ from what we knew until now when using TDM1. The next slide shows you the trastuzumab deruxtecan after TDM1 failure. And you know, of course, the slides, and they have been discussed very extensively in patients who are HER2 overexpressing. And you know, of course, that trastuzumab deruxtecan can be used after TDM1 failure, showing very well that this is something which works in a different way than TDM1 and still is valid in patients who have experienced a failure, having HER2 3+ overexpressing tumors and receiving trastuzumab with DM1 in combination. So the assumption was quite near to try trastuzumab deruxtecan in HER2 overexpressing patients, and not only in HER2 overexpressing patients, but also those who had a low HER2 expression, like 2+ or 1+. And the next slide shows you then the outcome of these experiments. And this is a phase 1b study with 54 patients with advanced or metastatic HER2 low expressing breast cancer. And you see that there was an over response rate of 37% and a disease control rate of 87%, with a median duration of response of 10.4 months, so which is quite remarkable. 98.1% of patients, however, experienced treatment-related adverse events of grade more than 3 in 83%, including neutropenia, thrombocytopenia, anemia, hypokalemia, and others. And 3 patients treated at 6.4 milligram per kilogram suffered treatment-associated fatal pneumonitis. So this is not necessarily something where you have to can be generous, but you of course have to watch possible side effects of treatment. However, it offers you still an option where patients with HER2 low overexpressing breast cancers might receive a certain drug like trastuzumab deruxtecan, which then might be effective in this context, particularly shown by the duration of response, which was more than 10 months, which is quite remarkable in this patient population, particularly in this patient population, because all these patients who were included in the study were refractory to standard treatment and had received more, or a median of 7.5 prior therapy. So these were heavily pretreated patients and still responding well to this treatment option, as long as they had the certain characteristic of HER2 low expression. The next slide. This shows you key adverse events. So once again, this is something which you have to watch. You have to watch, although you might be interested in delivering this drug, you still have to watch neutropenia, thrombocytopenia, anemia, in general hepatic toxicity, and interstitial lung disease. So interstitial lung disease, you definitely have to watch. I remind you of the occurrence of pneumonitis, something which is definitely worth observing and treating in time. The next slide shows you then the anti-tumor activity and safety in deruxtecan and HER2 low expressing advanced breast cancer, and the best change in tumor size. And this is taken from a publication by Dr. Modi from a very recent publication in Journal of Clinical Oncology. And you see in the upper quadrants all patients with immunohistochemistry 2+ and 1+ overexpressing, low overexpressing HER2/neu. Interesting enough, in the lower quadrant, you see that the responses were quite deep and were quite impressive in this patient population, be it HER2 immunohistochemistry 2+ or a little less so 1+. This is just a picture which corresponds very well with the biological situation of a 2+ overexpression versus a 1+ overexpression. Of course, 2+ being a better target than 1+, but still 1+ working in a certain amount of patients. The next slide. Now, you'll see here the results of this phase 1b study, again by Dr. Modi's paper, anti-tumor activity and safety of trastuzumab deruxtecan in HER2 low expressing advanced breast cancers, and the duration of response and PFS are both quite impressive, particularly when you consider that PFS was median 11.1 months and the duration of response was median 10.4 months. So this is rather impressive in the selected patient population. On the next slide shows you then the situation in the anti-tumor activity and safety in HER2 low expressing advanced breast cancers, and the subgroup analysis regarding overall response rate. And you see this quite well here, that the drug trastuzumab deruxtecan worked well in all patient subgroups, particularly those who are estrogen receptor positive, less so in patients who are estrogen receptor negative, but still in all patients, in all other patient subgroups, you definitely have the right to assume that the compound would be working. The next slide, please. Now, you see here that this idea of HER2 low breast cancers is being taken up by a series of trials, and that there are at least 4, to my knowledge, ongoing combination trials with immune checkpoint inhibitors and the novel anti-HER2 new agents in HER low breast cancer. Now, 1 is ongoing, 2 are recruiting, and 1 is not yet recruiting. And you see that these are combinations of trastuzumab deruxtecan with pembro, with nivo, with durvalumab, or in combination with chemotherapies. So these are, of course, quite logical choices, which would add to the armamentarium that we have in this very patient population. The next slide, please, shows you then finally our conclusions. Now, HER2/neu low breast cancers are very frequently represented among various breast cancer biologies. Now, the status may develop further to constitute a new disease entity prone to targeted therapeutic interventions. So I think we're not there yet, but we're on our best way to generate and arrive at a new subgroup of patients with breast cancer. Developing treatment compounds include a series of approaches, But right now, of course, antibody-drug conjugates in general and trastuzumab deruxtecan are the most advanced. Now, HER2/neu low characteristics show strong dynamics. And that is important that between primary relapse tumors, you will be well advised to do biopsies, which are strongly advocated to not only withhold potentially effective treatment for patients, but also to make you understand the biology of the disease that you're treating in the individual patient. Thank you very much for your attention. So, ladies and gentlemen, I have this question right now here. Is trastuzumab deruxtecan ready for prime time in HER2-low breast cancers? And I would say, well, maybe 50-50. We do not have a lot of clinical data on that. We have some clinical data. We have some biological assumptions. It's definitely not something which you would call state-of-the-art treatment, but it is something which you might consider in a certain biological situation, or particularly certain treatments are not available anymore. Just remember the publication with median 7.5 treatments preceding treatment of patients with advanced breast cancer, and those who are switching particularly to HER2 plus or even to HER1 plus disease. Okay, I see no further questions. No, okay. So please mind you that we do have with HER2-low breast cancers, we do have a new entity which is emerging, and please stay tuned and keep attention to this very, very interesting development, which hitherto has received not very much attention, but definitely will so in the very near future. So, ladies and gentlemen, we've arrived at the end of this webinar, and I want to thank you all for listening to us. I want to thank the faculty, Dr. Borštnar, Professor Bartsch, and I want once again to thank the CECOG group with Ms. Fischer and Mr. Dieterich making this event possible. Of course, AstraZeneca is to be thanked for the grant that we received, the education grant, and you will see very soon that we will have this seminar and webinar also present on our homepage of CECOG. So please stay tuned, and if you want to revisit this, please look at it on the www.cecog.org. Thank you very much, and stay safe and healthy, and all the best to you all.